Hello there, my name is Enock. Taking care of your health should be a top priority. Looking at the various engagements that we have today, it is so easy to forget about our health, mental well-being. That is why we introduce to you the Healthy You Talk Show, a brand new show that is going to address matters concerning your health, nutrition, stress management, mental health, name it. We bring to you a wide range of experts who are going to be touching pertinent issues concerning our health. Tune in every Tuesday at 10 a.m. live on Faith Today TV.
Mountain Moving Faith. This is my latest book. And if you want to learn how you can move mountains, life has many mountains. While this journey, you will encounter mountains and you wonder, how can I move mountains? This is a book to read. And it took me time to research, to pray, and to wait on God and look at the scriptures and what Jesus talked about moving mountains. And this book is quite a story, it's quite an inspiration. It is quite something that will change your life. So order your copy today. We can send it to you wherever you are in this country. We will be able to send this book to you on Mountain Moving Faith. Call that number or send a message and our team will be able to ship it to you wherever you are. There's a book to read. You can also buy for your friend, for a family as a gift. And I have no doubt they will thank you and that they will be always thankful for what you have done for them. So God bless you as you read this book, Mountain Moving Faith.
Hello there, welcome to the Healthy You program, your favorite health program on Faith Today television. My name is Enock Kitondekijja, a medical clinician and your host. Today's topic is hernias in boys and girls. And the argument is, what should parents do? For those of you who are planning to be parents, this is very special for you. But before we dive in today's motif, allow me recognize JCK Hospital. Now, JCK Hospital is the official sponsor of this health program. You can find them in Roysambu along Lumumba Drive, just next to Happy Life Children's Home. They are also in Juja Farm. Are you in Juja? Find them just next to Happy Life Christian School. And for those of you who are in Muranga, good news is in Maria Ine, JCK Hospital is found there. I have something good for people in Mirema. I hear something is rising up in Mirema for you. Now that is JCK Hospital, and our passion is bringing you holistic health. Our passion is making sure that you are fully equipped with knowledge so that you can be able to live healthy in the mind, in the soul, and your body. Now, as we enter into today's discussion, have you seen people who are wondering where hernias come from in children? You've seen people asking, but we thought hernias are only for the elderly people. Do children also suffer from hernias? As if that is not enough. When they come to hospital, the doctor tells them, you see this? Now this was hernia, and the only thing we can do is just operate on your children. Now what does this mean to our parents? What does this mean to the caregivers? This is why this conversation is very, very important. And to help us unpack this motive today is a consultant pediatric surgeon from the University of Nairobi. He's part of the surgical, the SS Surgical Society. of Kenya. Dr. Mugo is right here with us. And before I invite him to give us the detail and introduce himself fully, I want you to do one activity. You know how we do it? You invite your neighbors, inform someone about this program on Faith Today television. Very, very important. And I know there are those who are following this show at home, in your offices, you are driving, you are tuning in on Facebook and YouTube. You do so well. We encourage you to like, subscribe, and share. And to the person who has received this, please do the same. Let this message of health go over and over again. You don't know who you could save or help with this kind of information. Thank you so much. Those of you who are following us on TV, that number on your screen, utilize it. If you have an urgent question, please let it come through. For the earlier, the better. Doctor, a pediatric surgeon, is in the house to help us understand this. Back to my guest today, Dr. Mugo. Welcome to Faith Today television. Would you kindly introduce yourself officially to our viewers?
Yes. So thank you so much for having me here. My name is Dr. Robert Mugo, and I'm a consultant pediatric surgeon. That means that my line of work is seeing children, so 0 to 18 years, who have conditions that are treatable using surgery. And pediatric surgery is really the surgery of any disorders of the digestive tract or the urinary tract, so around the abdomen and the groin and the pelvis area. So that is what I work on. Most of the time, children are born with these disorders, so pediatric surgery encompasses a wide range of conditions, starting all the way from the very small babies, premature babies, all the way up to 18. And the conditions that you deal with can be conditions that the baby is born with. These are called congenital conditions, or things that the pediatric patient can acquire. These are called acquired conditions, things like infections, or even trauma, if the child suffers an injury. So those are the kind of patients I treat. They work in most of the hospitals around Nairobi, and one place where I do a lot of operations on children is at GCK Hospital, and I thank them for inviting me to come on this program and share some more on these topics with you. So thank you.
Wow, that has been a very unique introduction from Dr. Mugo. We're happy to receive you here at Faith Today television. Yes. And for those of you who are following us, when we have a consultant, you really don't want to miss this segment. You really want to be keen to understand what is it in for you. For example, parents, and those of you who are planning to become parents, we have a consultant. Let your questions come through right now. Dr. Mugo, our viewers would want to know how your day looks like, your typical day for a consultant like you. Okay. How is it?
So, so my typical day, it's easy, I think, to describe a week, since that is how I usually plan my schedules. So since I am a consultant in pediatric surgery, obviously my main line of work is operating, okay? Yeah. So normally I like to plan my week ahead. So there are days when I will do clinic, meaning that I will come, sit down, see patients. Usually will be parents that have brought in their children in for some sort of checkup because they have a concern. So there are days in which I do clinic. You'll find my busiest clinic days usually Wednesday and Thursday. Like now we do a clinic Thursday afternoon, every Thursday afternoon at JCK Hospital. And then there are days when I will do planned. So when after I see these patients, I usually schedule them for an operation. So these are the scheduled or elective operations, in which case you are told the date and the time to come. And this also gives me and wherever I'll be operating ample time to prepare, so that by the time you come, you find everything is ready for you. We know that you're coming in at this time, we'll want to operate. So usually in babies and children, it is best to operate early in the morning. Okay. And then we can have an ample time during the day to watch them recover. So my main operating days are usually Tuesdays and Fridays, and sometimes Thursdays. Oh. So those are the days when I plan operations. However, in the nature of this work, you know that there are also emergencies that arise, like situations in which case you haven't planned. A baby has come in with an emergency and you need to come in right away. So those ones, of course, you cannot plan for them. If there is an emergency and I am the one who has said I will make myself available in case there is an emergency, then I will definitely attend to you, whether it's day or night. And now that is the bit that is unpredictable.
Oh.
But otherwise, I usually have days when I see patients in clinic, days when I operate, and other days when I tend to my other administrative duties in the course of my job.
Wow, that is quite interesting, because knowing that in the mornings you guys are mostly busy, meaning you have to wake up when you are really sharp.
Yes.
I've heard of a planning bit. You guys plan for these surgeries.
Yes.
They should not just down on you.
Yes.
And that is really interesting. And that you are also working closely with JCK Hospital.
Yes.
Wow, that is good to know.
Yes.
Speaking of your kind of schedule, that is why probably we have you here today. It's not been easy, you know. I've tried to get you come, but you've always postponed and things like that.
Yes.
We have an urgent need that we really need to address. Yeah, the hernias in children today.
Yes.
Like we began, you know, there are people who say children do not suffer from hernias. It is only the disease of the elderly. So would you give us an overview of pediatric hernias?
Okay.
Yeah.
Okay. So this is one of the commonest conditions that we deal with as pediatric surgeons.
Yeah.
So hernia is a common condition, as you've said. Quite a number of people suffer from hernias, and it's known to be, as you said, a disease of maybe the elderly, or usually is in young men, maybe who do a bit of heavy lifting, you know, weightlifters, people who work on the gym, people who work on construction sites.
Yeah.
So it is usually odd when, you know, a parent brings in their child and you tell them that they have a hernia. But however, in children, this is as I mentioned earlier, this is a condition they are born with, congenital condition. So in children, what normally happens is that there is usually an area of weakness on the muscles of the anterior abdominal wall or the muscles of the stomach. So there is usually an area of weakness right around the groin area. This is the area around which your waist will be if you put your hands on your waist.
How you can probably show us how
yes.
that.
Somewhere here, yes.
Somewhere
Yes.
around the groin.
Yes.
That is the waist.
That is the waist, yes.
Okay.
So there is usually an area of weakness. It's a tunnel usually. In boys, this is the tunnel that enables the testicles to descend, to come down into the scrotum. So it's something that's meant to be there. It's only meant to allow the testicles to descend, and after that it closes off on its own. But now in the situation whereby after the testicle has descended, now that area does not close off, then it remains as a weakness or as a hole in the anterior abdominal wall, in the muscles of the abdomen. Then through that hole, in other organs in the abdomen, usually you can have the intestines, fatty tissue, even fluid within the abdomen, will try and make its way through that. So for parents, I usually say that it's like, you know, if you want to come into a room, we'll open the door for you. So the door is like when the testicle wants to descend into the scrotum, it passes through that door. But after they have come into the room, I usually close that door so that nobody else can come in when you're having a consultation. But if that door remains open, then other unwanted visitors can keep popping in and out through the open door. And that is exactly what the hernia is. So usually it will manifest as a groin swelling. You will see a swelling, but the problem is not really the swelling as such. The problem is that there is a hole in the anterior abdominal wall, and since now we are talking about a place that is defective, there is no medical treatment for that, unfortunately, and that is why hernia is a condition that is treated by operative repair.
Operative repair.
Yes.
And I like the fact when you come on strongly that there are no medical treatment for this, and I will definitely put you on a hot seat, because I know there are parents out there who are not comfortable seeing you, you know, open their babies. You know, they're not reluctant to really just you know, avail their babies for such. Before we get in there, these days there are so many operations of pediatric inguinal hernias. Why is that so? Is it that you guys just have fun opening these kits because you have studied.
Yeah.
Tell us, why are they so common these days?
Yes. So, as I've said, all babies are usually born with an inguinal canal. It's part of the normal anatomy.
Even all of us.
All of us have an inguinal canal. It's just that it's supposed to close after the testicle has descended. And even girls, even if they don't have testicle, you know, the design of the human body is really the same. So even girls have an inguinal canal. However, of course, this condition is much more common in boys compared to female, about 3 to 1. So 3 boys for every 1 girl who is affected.
So meaning, for our viewers, it is not only boys. I've had you explore the reproductive system for the boys.
Yes.
And then you have not talked so much about the girls.
Yes.
But I like it when you bring it to light that also girls are affected.
Also girls are affected.
So for the parents who are watching this is Faith Today Television, and keep it now.
Yes.
Faith Today Television.
Yes.
Yes.
So when studies have been done in the overall population,
Yes.
it's seen that this is a condition that affects 1 in every 20 of
One in
children
every
born.
20.
1 in every 20. That is 5%. So quite a common condition. Now, nowadays, we are picking it up more. So it's not that it's a condition that's arising suddenly. It used to be there. It used to be silent. People don't know what is happening. You know, there are some unfortunate cases that we receive patients from outside Kenya, East Africa, or remote areas of Kenya with neglected hernia. And they come in when now the hernia is very large, very swollen, the patient has been suffering, and they've not had access to the help they needed. And you know, by the time they come, now the patients are in a really bad shape. But thankfully, where we are practicing in Kenya, there is good access to healthcare system. There is a good access to midwives, nurses, pediatricians, doctors, clinicians, and all these now parents can actually bring their child when they're coming in for a checkup, or if the child is starting not to look sick, they can quickly seek the attention of a healthcare provider. And then the healthcare providers are also aware. We know that this is a condition that can happen, and they bring it very quickly to the attention of the surgeon, so that now we find them early and repair them early. So it's not like it's a new condition that's now suddenly arising. It's been there, but right now we recognize it and we treat it early. As I said, it's a relatively common condition, 1 in every 20 children. It's more common in boys. It's more common in premature babies. So again, we have more premature babies.
Talking of prematurity,
Yes.
I think that is key.
Yes.
What brings about prematurity in babies?
Yes. So we know due to various conditions, either obstetric or fetal, these babies are born early. So there are many conditions that can arise. Maybe the mother starts bleeding, labor starts early, you know, a variety of conditions. And with the medical care we have right now, more of these babies are surviving. So again, premature delivery is not something that is suddenly arising. But what is different now is that while in the past, a lot of these premature babies were unlikely to survive, right now the premature babies are, you know, we have incubators, we have all these medications that can help babies breathe nicely in the first days of life when they need help. We have nutrition that we can give the baby intravenously. So these premature babies are surviving, more, and now we can see. Of course, when it comes to prematurity, you know, this inguinal canal is supposed to close off at a certain period of gestation. So if the baby
is that?
It should be about week 28 to week 32. So between 7 and 8 months of gestation. That is when now, if there is testicular descent, or in case of girls, that is when now the testicle should pass through the inguinal canal and then it should close off. So babies who are born premature before term have a higher likelihood of developing hernia. Commoner in male children, has said that. Sometimes, in rare cases, there's a family history of hernia, so especially in first-degree relatives. So if your mother or father had a groin hernia, patients are slightly more likely to have a groin hernia. And then now in childhood, conditions that cause increased straining within the abdomen, within the stomach. So patient with cough, you know, patient who has allergy, keeps coughing.
Now that is past the prematures.
Past the prematures.
Okay.
Yes. So, but in early childhood. Yes. Okay. So patient maybe who has an allergic disorder, or, you know, allergy to dust, keeps coughing. and they open up the inguinal canal. Patients who have constipation or hard stool, so they keep straining when they're trying to go to the toilet again, have a higher likelihood of developing inguinal hernia.
Wow.
Yes.
Thank you so much. And I agree that you are giving us great information. For our viewers, we are talking about pediatric inguinal hernias. And doctor here tells us that these are hernias that have been with us for a long time, you know. It have been with us for a long time. So it's not just that it is propping up these days. It's only because people are able to identify them and then deal with them. But now could be a challenge, doc, you know, because, you know, these are babies, they cannot tell. How can you help parents identify these hernias before they maybe become worse, or, you know, something like that? Help our parents understand how to identify, then deal with the problem.
Excellent. So one good thing about surgery is that our conditions are visible.
Yeah.
You see that something is wrong. So in the case of an inguinal hernia or a groin hernia, there will be a swelling in the groin area, sometimes extending
a visible swelling
in the groin area, which was not there before.
Yeah.
Starting from the groin area and sometimes extending all the way down into the scrotum for boys or into the labia for girls. And this swelling, what usually happens is that it's intermittent. So it's usually there. Sometimes it's there, sometimes it is not there. Okay. Yeah. Because sometimes, you know, a baby might just be well fed and chubby and they have a bit of fat in that area. Yeah. That is not a hernia, you know. But a swelling that will appear sometimes, and sometimes it's not there. So when you're changing the diaper, when the baby is crying or fussing, you will see something come out and go all the way down into the scrotum. It's usually quite dramatic. And then usually when the baby settles down or with time, the swelling disappears. So that's what the parent will be coming, and that's usually the chief complaint, that my baby is crying, and when they cry, I see something appearing in the groin and going all the way down into the scrotum. So that is what is called a reducible hernia. And now that one, of course, is something that you need to bring your baby in for checkup and have a medical professional deal with it. In some cases, because now a reducible hernia means the abdominal contents are coming out and going back in by themselves. Usually it's the intestine. So sometimes the intestine can be trapped. So I usually tell parents, think of it as maybe the door is half open and then you're trying to get in, but you can't make it through all the way through, and you also can't come out. So you're trapped in between. And now that is a situation now where that now starts becoming an emergency. Because a trapped intestine cannot conduct food, cannot move food the way it's supposed to. And usually you will find what happens right now is now the baby starts feeling pain, so they are crying continuously. The swelling now will not be intermittent, it will not be reducible. So there will be a constant swelling, it might even start appearing red. The baby will be crying continuously, very uncomfortable. The entire abdomen or the entire stomach can swell, so you'll definitely know something is wrong. And the baby will also be vomiting because food and other intestinal contents are not passing. So the baby will be vomiting.
Because speaking of that, Doc, it's very interesting for us. For example, someone wants to understand. Because of the challenge of intermittency, you know, when should surgery or something be done? Because the child can cry and then they stop crying. So the parents take it lightly. Should surgery or an operation be done immediately, or at what point do you guys come in?
So for hernias, they are operated as soon as they are diagnosed.
As soon as you see?
As soon as you see, it needs to be closed. Because you see the first scenario I've explained, the reducible hernia, in that case now, those are the patients you plan for surgery. And you don't plan it next year. Maybe you will come in to clinic on Thursday. We'll say we'll do this tomorrow. You know, come in at this date and this time and we can plan for it. But now the scenarios that now I'm continuing to describe, like where now the hernia is trapped, or in even more if the entrapment of the intestine continues, even that portion of the intestine loses its blood supply and dies off completely. So you have a portion of dead intestine. And this is an extreme emergency that can lead to widespread infection and even death. So that is an emergency. So for those cases of an irreducible hernia or even now the case where the intestine has lost its blood supply and died. That's called a strangulated hernia.
Strangulated.
Yes.
Yeah.
So those are true emergencies, and those are now the patients in whom you will have to come in and do an emergency operation even in the middle of the night on a very sick patient. So we do not want that. Usually we want to repair the hernia when the patient is relatively okay, because the procedure is relatively straightforward, as opposed to doing an emergency procedure and then have the patient have a prolonged recovery from being very sick.
Wow. Thank you so much, Doc. And I hear you. It's now time that we understand whenever you see a bulge for the parents, the consultant is telling us that is the day, the time you need to really take action. As a parent, you don't postpone. Even if the child has stopped crying, that is when you come to the hospital before complications arise. And before we move to the next stage, because I know our viewers have questions,
yes.
I know questions are coming through. Briefly tell us, Doc, you know, in the African setting, we are so much accustomed to alternative medicine.
Yes.
Yeah. We've had certain success stories with herbs. Some people utilize herbs and they have worked for them. Tell us about the application of herbs on hernias.
Okay.
Yes.
So there are a lot of, as you said, alternative treatments that have been tried.
Yes.
Success rates, however, is a different story. You know, trying something and it succeeding is a different story.
Yeah.
So usually, a good analogy I usually like having is because either parents drive or own a bicycle. You know, those are common things that parents know. So if you have a bicycle that has a puncture, or your tire that has a puncture, what herbs do you try applying herbs to the tire that has a puncture, or do you mend the puncture?
It's a bit obvious.
Yes, it's quite obvious. Yes, if there is a place that has a hole, you mend it. Even your dress, if your dress or your trouser has a tear, you take it to the tailor. You do not apply herbs on it. So that is the same thing that I will tell parents. This is something that there is somewhere that a hole is present in the body, and this hole just needs to be repaired. And the treatment is safe, effective. It works. It works very well, and the recovery, especially in children, is usually very, very rapid, because you know these children are growing. These children are otherwise healthy. They do not have other conditions like diabetes, hypertension, you know, chronic heart disease. You know, they only have that one issue that is wrong with them, and once you sort that one out, they usually take off and heal very fast. And that is actually one of the joys and one of the things that is very satisfying about pediatric surgery, is that usually dealing with generally healthy patients who usually just have one issue with them. And once you sort out that issue, usually the patient makes a complete recovery and can go on to enjoy the rest of their lives with no further consequences. Yes.
Wow, this is quite interesting. For those of you who've been attempting or even indulging in herbs concerning hernias, you have an answer from a consultant. Once again, this is Faith Today Television, and we have Dr. Mugo, a consultant pediatric surgeon in the building. If you have any questions concerning pediatric hernias, this is the time where you send them, because we are going to have a short break. And when we return, doctor is going to share with us his experience. We are now talking about personal experience, dealing with such clients. You want to hear these guys' experience. And as if that is not enough, we want now to discuss with the parents, what can you do to prevent all this? We want to give you so much content in the second part of this. Do not change your dial. Keep it Faith Today Television. Catch you when we come again in a few minutes from now.
Okay, asante. Nilikisajili kitabu ambacho kinaitwa 7 Keys to Success, ama kuna kanuni funguo 7 if you like it, ambazo zitakuletea ushindi na kufaulu maishani. Wote, wewe na mimi, tunataka kufaulu, lakini pia kuna njia ya kufaulu. Ukisoma hiki kitabu ambacho nilikiandika kwa kufanya utafiti, kwa maombi mengi, kuangalia neno la Mungu, I have no doubt ya kwamba hiki kitabu kitabadilisha maisha yako. Nilikuwa naongea na mchungaji rafiki yangu akaniambia, nilisoma hicho kitabu, sasa ninafundisha watu wangu kupitia ujuzi, maarifa, hekima ambayo nilipata kwa hiki kitabu. Kwa hivyo unaweza pia nunulia watu wengine, na akaniambia alinunulia hata viongozi wake, na wamekuwa wakisoma, wakaweka kwa library yao wanasoma. Hiki kitabu sina mashaka, nina uhakika itabadilisha maisha yako na utabarikiwa. Tuma message ama upige simu kwa hiyo namba, na naweza kuwasiliana na wewe na utapata hiki kitabu, utatumiwa, usome na ubariki pia watu wengine. Asante. Mungu akubariki unaposoma 7 Keys to Success, and you will succeed. Thank you.
Hello there, my name is Enock. Taking care of your health should be a top priority. Looking at the various engagements that we have today, it is so easy to forget about our health, mental well-being. That is why we introduce to you the Healthy You Talk Show, a brand new show that is going to address matters concerning your health, nutrition, stress management, mental health, name it. We bring to you a wide range of experts who are going to be touching pertinent issues concerning our health. Tune in every Tuesday at 10 a.m. live on Faith Today TV. Hello there, welcome back to the Healthy You Talk Show, your favorite health program on Faith Today Television. In studios, we have Dr. Robert Mugo, a consultant pediatric surgeon with so many years of experience, and we've got a very good time in the first segment where he has given us an overview of these hernias. He has talked about the application of herbs. We ended it at that time, and I know parents are really loving this show because this is a time to save lives. Now, for those of you who are sharing this content, you are helping us reach thousands of people with this message so that people do not make mistakes in the era that we are in right now. Before we took a short break, Doctor was giving us, was about to give us an experience of him handling these clients, these patients, and we want us to also get this experience firsthand from him. Today we are also going to understand some of the challenges the healthy workers get. But before I invite him again, I've seen people sending in their questions, and this is quite interesting because it shows that you guys are following this. You are ready to save lives and become better parents. Someone is sending in a question from, who's this? Jose in Kimbo. Do I need to worry about a certain age group with high prevalency of this condition? That's question number one. Okay. Question number two is Mary in Keno. Keno people, we love you so much. Mary says, can I recognize hernias in a little kid like 6 years? How? That's Mary in Keno. Before we go into our discussion, first handle those first two questions.
Okay, great. Thank you. Thank you for those questions. So for the first question, increased hernias in certain age groups. Yes. So the commonest age group of which will suffer from pediatric inguinal hernia are the premature babies. Up to a third of them will end up with with an inguinal hernia. And as I've said, this just happens because they were born before the due date, and the inguinal canal, which was supposed to have closed at a certain date, just doesn't. So it's not all premature babies. It is 1 in 3. But again, you see, this is much higher than the general population, in which it occurs in 1 in 20. And again, it will be mostly male boys. So premature male boys have the highest incidence of inguinal hernia. And in fact, of those, they usually tend to have hernias on both sides. So usually a hernia can either be on the right side or the left side. But especially for premature boys, they have a much higher incidence rates of having hernias on both sides. So that will be the age group that has the highest incidence of pediatric inguinal hernia. As to the second question, how will you recognize a hernia in a 6-year-old patient? Again, it's a groin swelling. So a swelling that's appearing around the waist region and extending all the way down into the groin area, so the scrotum or the labia in girls, that appears and disappears, sometimes associated with pain. So a 6-year-old, well, a small baby will just, cry, be fussy, and you're wondering what's happening. But a 6-year-old, now this is somebody who can talk, and they will say, I feel pain, and they point at the area.
Point where the pain is. Yes.
And then usually in those cases, maybe by the time they are coming to see me, maybe the swelling might not be there, but based on the history, so they're saying, oh, this patient, my baby has been saying they have pain here and there's a swelling that I saw maybe 2 days ago, but right now it's not there. Now they are imaging tests, so usually it's an ultrasound. So you send them for an ultrasound, and the ultrasound actually focuses on that area and actually sees where the defect is. And now that is what actually confirms the diagnosis for you. So inguinal hernia is a clinical diagnosis. You do not need an ultrasound to diagnose it. But in cases of doubt, an ultrasound will pick it up very fast. Yes.
Thank you so much, Doc. Mary in Keno, I hope you get the answer, and as well Jose in Kimbo, send our regards to people in Kimbo. And I think this other question ties into what you've talked about, history.
Yes.
Someone is asking, good morning. Today we are learning a lot. Doc, are there clinical history findings associated with pediatric hernias?
Yes. So history, usually classical. Intermittent, so that's the first one. It should not be there all the time, because if it's there all the time, as I've described it, that is probably A, not a hernia, or B, a surgical emergency. So an intermittent, so it's there sometimes, it's not there sometimes. And then the location is the groin. Then it extends down into the scrotum, and it appears when this child is crying or straining. So that is the classic history of a reducible inguinal hernia.
Something that you can take back.
Yes.
All right.
Now if it becomes an irreducible hernia, so the history will be that this swelling used to come and go, but right now it's there all the time, and this child is crying all the time, No, those are not patients who will come to clinic. Those are patients who go to the emergency room. Yes, these are not patients who will come, queue, what. So these ones, they are taken to the emergency room and they give that history, and you're called in and you deal with that as an emergency, okay? So the key history findings is a groin swelling for inguinal hernia. Yes.
Questions are coming in handy, but before we get to them, you have a debt to pay. You're supposed to give us an experience of you handling this
hernia.
Yes, hernia.
All right. So usually, as I've said, so most of the time the hernia will be picked by
your personal experience.
Yes.
Give us a case study.
Yes. So that's what I said. For instance, in the hospital I work, for instance, at JCK Hospital, this patient might come in, let's say on a Monday afternoon, a day when I'm not scheduled to be there, but they will find a medical provider. And they will give them that classical history, that there is this swelling here, it's present on and off, when the child is crying or straining. And the medical provider there suspects that this is a hernia. So what do? They say, they'll tell the parent, this is a groin hernia, and you need to see a pediatric surgeon, because that is a professional who can fix that problem. So now if it's reducible, they'll make an appointment with me. So by the time now I come in, I'll already have been briefed by the primary care provider. Okay, there's a patient in whom we are suspecting a hernia, please see this patient for us. So when I come and meet the parent, they are there with their child, I usually tell them, okay, let's just examine and confirm this is the diagnosis. So I will examine the child. It's usually best if the child is comfortable. So if it's a small child, you examine them on the laps of the mother. If it's a bigger child, they'll have to lie down on the examination table, make sure they are comfortable, because you need them to be relaxed for you to have good examination findings. And usually for the young child, maybe when you start taking off the diaper, they'll start crying. So that will actually, if a hernia is there, you'll see it popping out very nicely. Sometimes the parents have pictures or videos on their phone. Those are also very helpful. So again, for parents out there, take a photo. Nowadays, a lot of people have smartphones. So if you see something funny, take a photo before it disappears, and then you can show it to the healthcare provider. That's very helpful.
Before you proceed,
yes,
taking photos is very key.
Yes.
Taking these videos in a digital era,
yes,
just to help you guys also work well.
Exactly. Yes. So I'll examine, confirm that, see that the swelling is there, try to reduce it. So confirm the diagnosis of a reducible inguinal hernia. Sometimes in the case where in the examination room I can't elicit anything, or sometimes they might already have been sent for one, I will send them to do an ultrasound test, yeah?
Again, why do
Yes.
you do an ultrasound scan? Because something is visible.
If it's visible, no ultrasound. As I've said, inguinal hernia is a clinical diagnosis. So if it's visible and it's obvious, it's an inguinal hernia. There's nothing else it is. You have your diagnosis.
Okay.
But as I've said, sometimes you can't elicit any sign in the examination room. Very commonly though, they'll have seen somebody else and they'll have been sent for an ultrasound. And then when the ultrasound findings now come back as inguinal hernia, that is when they are sent to the pediatric surgeon. That's when they are sent to me.
Okay.
So you'll see them already with the ultrasound, but I will not rely on it to make my diagnosis. So the ultrasound just confirms presence of hernia, how big the hernia is, what side it is. An ultrasound is nice is because sometimes it can also take a quick look on the other side and just confirm that there is no hernia present on the other side. Okay, so based on the ultrasound, based on the clinical findings, now once I have the diagnosis, I'll sit down with the parent and explain that your child has a hernia, this is what brought it about, and the mode of treatment is basically an operation.
Yeah.
So I will take the parent through what the operation for their child entails. So as I began earlier in the program, for pediatric surgery, it's very good to plan these things, you know. It's like any complex undertaking in life is planned.
Yeah.
You know, even that's why SGR, you're told to be at the train station at this time. It's not that the train will arrive at that time.
Yeah.
You know, the train has already arrived, it's been cleaned, it's been packed. There are very many things going on in the background so that the train can take off exactly at 3 p.m.
Standard operating procedure.
Yes, so that's the same thing. So even for if we are doing surgery on a child, ideally we'll say we'll start the surgery, for instance, at 8 a.m. I usually like doing the surgery early in the morning. So the child will either come to the hospital the day before or very early in the morning. If you can be in the hospital by 7, well and good. If you can't, come the night before, spend the night in hospital. And then before the surgery, we usually like to do some, you might take a blood sample just to make sure the child is okay for the operation, make sure their blood levels are fine. If they are healthy and they have no other disorder, you know, you may not need to do these blood tests so much. Then you also need to plan with the theater team so that everything is ready.
Yeah.
Depending on the age of the child. For instance, if it's a very small child, we will need very small special instruments, you know. So all these things have to be put in place before you just show up for surgery. You will need very small stitches that you're going to use. You will need to have ordered whatever drugs, dressings that you need. Then again, when it comes to surgery, another person who is very important and very key, without whom no surgery can take place, is the anesthesia care provider or the anesthesiologist. This is the one who will put the baby to sleep. So again, you need to coordinate with them, tell them about the condition of the baby, the weight of the baby, because all the medications in pediatrics, you know, unlike adults, you know, you say take 2 tablets of Panadol. But for babies, the dosages have to be calculated precisely based on their weight.
Sensitive.
Yes. So you'll inform them about the patient, and usually you'll find even the anesthesia provider comes in earlier. On the day of surgery, they'll come in before the surgeon and see the patient themselves and prepare them for what the anesthesia will entail. So for the parents, before the anesthesia, before the baby is subjected to anesthesia, we usually tell them to bring the baby with an empty stomach, because usually anesthetic drugs unfortunately have side effect of causing nausea and vomiting. So if the patient has a full stomach, once they expose the anesthetic drug, there's a high risk of them vomiting.
I'm actually understanding that it's really a procedure that you guys take.
Yes.
You don't just have operate on someone. You prepare.
We prepare.
You prepare the patient.
Yes.
You also prepare your team.
Yes.
You know, I like that.
Yes.
And because I see it's already clear that you guys already have a plan. And now the urgent question is, Doc, are there incidences where you've operated on a kid or a child and then the hernias reoccur? Are there such incidences, and what causes that?
Yes. So as I answer that question, I can continue. So now on the day of surgery, let me talk about the day of surgery. So they'll come in at that certain time, we'll do the operation. The operation is fairly straightforward because it's known where the hernia is. You're not going to look around. Again, usually this is something that you can reassure the parents that we're not making a big incision or a big cut on your baby. We know where the problem is. We'll go directly to where the problem is. So the cut is usually very small if you are talking about open surgery. 2 centimeters maximum, 2 centimeters. Go direct, see where the hernia defect is. Usually in boys, the structure that has passed through there are the blood vessels and the vas deferens that's going on to the testicle that's in the scrotum. So that is what you need to be careful when you're repairing a hernia in boys, because those vessels are nearby, but you see them. Keep them out of the way, repair the hernia, and then come out. It's a procedure that takes about 40 minutes, fairly straightforward. Put on a dressing. The recovery is usually rapid, especially for the patients who come in early in the morning. We can even observe them in hospital for about 4 to 6 hours to make sure that all the anesthetic medications have worn off, and then they can go home the same day. However, for patients who are less than 3 months old, especially now the premature patients who are among our most common patients, those ones have to stay in hospital just for overnight observation, and then they can go home the next day. The recovery is usually very swift. The only medications we give them are painkiller, basically, so the patient is not uncomfortable after the surgery. And usually when you tell the parent, give this painkiller on a timetable, every 8 hours. Don't wait for the child to be in pain, then give the painkiller. Just give the painkiller on a timetable, and they'll find that this child is comfortable. They are playing, they are crawling, they are happy. They don't know what happened to them. Within 3 days, the skin has healed. The skin incision has healed. So you can even remove the dressing after 3 days at home, and the child starts bathing normally. So inside where the hernia has been repaired, takes about 6 weeks for complete healing. So if it was an older patient, or like let's say an adult who's weightlifting, you'd say no gym, no heavy activity for 3 months or so. But hopefully you're not letting your child do heavy lifting. If it's an infant, obviously they are not doing any of those things. So they can just crawl, walk around as normal, regular diet, and the recovery is extremely swift. Now you had a question about the hernia reoccurring after surgery.
Yes, that sounds very key.
The surgery has been standardized and it's been perfected over many years. Right now we have better instruments, smaller instruments, better stitches that are dissolvable. So from when these hernias were first described and the surgical repair was first described, in the late 1800s and 1900s, to date, the kind of stitches that we are using is night and day. So the current recurrence rates are less than 1%, less than 1%. And there are as well nowadays a lot more modern techniques.
What could cause the recurrence, Doc? Because we want to address that. So that we can, stop that.
So usually the number one cause of the recurrence could be due to a number of factors. Number one, you might think that the hernia is small, so you only repair a small area, but you find the area of weakness is bigger than you anticipated. And it might not be as obvious when you do open surgery. So that is one area where open surgery is good for a majority of cases, but in those cases where the hernia might be bigger than what you see on open surgery, now you will have a recurrence rate, a higher recurrence rate.
Doc, speaking of those challenge, now it is not on the baby. It is with you guys who are operating on the baby.
Sometimes.
So tell us more of the challenges that health workers who are dealing with such conditions should anticipate and probably deal with, so that we do not get complications and recurrences.
So number one, and by far the biggest one, should be that pediatric hernia repair should be done by pediatric surgeons.
It must be done by a
pediatric surgeon.
Not quackery.
Not just any healthcare provider, not anybody holding a scalpel.
For the parents, this is very serious information. These people who are working on you should really produce their credentials to show you that really they are qualified for the work they are doing. Good.
That is the most important things. Parents out there, please look for a because pediatric surgeons are available. Almost every county, every major hospital now has a surgeon who only deals with the care of children. So take your child to a pediatric surgeon and you will be guaranteed that they'll get the standard
Other
of care.
challenges?
Now the second challenge, as I was saying, was that the hernia might be larger or the defect might not be exactly where you think it is. And this is where newer technologies like minimal access or laparoscopic or keyhole or video surgery now really come into play.
Now that is technology.
That is now technological advancement. So using this video surgery, what you do is you can actually put in a camera into the abdomen. And this camera I'm talking about is not like a video camera. It's something that has a diameter of 1 centimeter or sometimes 5 millimeters. So 10 millimeter, 5 millimeter camera. And now you look at the groin directly from inside. And you can see the exact area of weakness and how big it is that you need to repair. And then using this technology, sometimes you can even still repair from outside or even use very, very small instruments, 3 millimeter or even 5 millimeter instruments, and just repair the area you need to. And you can see in the end, I've said open surgery, maybe the incision is like 2 centimeters there, so total 20 millimeters. But if you are doing minimal access or laparoscopy or video surgery, the camera will be 5 millimeters. And really very small. Tiny, yes. And the instruments you're using are 3 millimeters. So total incisions will be 11 millimeters, very small. You can hardly see the scars and once you are done.
Also it contributes to the faster recovery.
Much faster recovery. As well, you can visualize both sides quite well and make sure that there is no hernia. So once you've done repairing whichever side had an issue, you can take a quick look at the other side and ensure that there is no problem. And if there is a problem, you deal with it at the same time. So it's much faster recovery, much less pain. Excellent.
Thank you so much. You allay our anxiety. Right now we are confident now. I am sure parents are gaining the confidence because there's a question that is coming in from one of our viewers. He's still consistent. He says, I'm curious, Doc, is it possible to shrink my hernia naturally?
His hernia. I doubt it. There is a baby who's typing on WhatsApp.
I think it's an adult.
He's an adult. That's what I'm saying. It must be an adult talking.
That one will require.
No, adult hernia.
Serious, immediate cancer.
Adult hernia is a different topic from pediatric hernia. But to summarize, you see, for pediatrics, they are born with this condition. When an adult gets a hernia, unfortunately, it's because that part of the anterior abdominal wall, which was previously fine, has now failed for one reason or another. It's become weak for one reason or another.
And Doc, allow me, because of time, we're about to wind up this show. But I think we need to arrange another day. You come in and then maybe talk about hernias in adults. There's a person here, I think he's saying, my boy has hernia, but I'm reluctant to do the operation. What should I do? Please answer that one.
Okay. So, yes, please, for the parent
you tell them
whose boy has a hernia, please bring him to hospital today. Yes, I mean, I'm saying this is a condition that is easily treatable. Don't let your boy, because hernia is a ticking time bomb, basically. You see right now he's okay, he's playing, maybe the swelling comes and goes. The time when that swelling will become irreducible, you will bring yourself to hospital at 2 a.m. in the morning.
I know.
So do not wait for that to happen.
So the earlier,
just come, we plan, do the surgery. Within 3 days, your boy has recovered and is back to normal activities. Otherwise, as I said, any boy with any patient with a hernia that is a ticking time bomb, just waiting to become an emergency.
Doc, I want you, before we conclude, there was this urgent question I want you to answer. We've had a challenge whereby mothers are so much involved in health care for their children, but fathers are left outside. I want you to address this. How do both parents engage in helping to identify, detect these hernias early? I pray you look at the camera and address this today.
All right. Yes. So for the most of the time, by and large, you find mothers are usually the primary caregivers of the babies, and they are the ones who are much more likely to notice that this hernia is present. Maybe when they are changing the diaper, they are playing with the child, they are trying to feed the child, and this child is having difficulty feeding, they are acting fussy. So they'll often be the first to notice. But this is not to say that fathers are left behind. behind. You know, of course, nowadays in this modern era, a lot of fathers are also taking up caregiving roles. They might be the one who's changing the diaper in the middle of the night, and they notice there is something wrong. For older boys, interestingly also, whenever they have a problem with their private part or groin area, the person they are likely to go to first is the father.
The father?
Yes.
Okay.
So this is where you'll find, especially in older boys, it will be the boy has gone to the father and showed him, and then the father can see and say, this does not look like what it's supposed to look like. And now they bring the boy to hospital. So in all cases, parental involvement is key, parental support. They are there to, first of all, support the baby as they go through a surgery. Of course, you know, any surgery, even if I'm explaining it's routine and easy, it is, of course, a significant effect in the life of this child. You know, they are away from home. There'll be a brief period where they are unconscious. They are in a strange environment. So they need the parents to be there to provide the calmness and the reassurance. We can't, as healthcare providers, we'll try, but, you know, we are strangers. We are in a white coat. They are not usually happy to see us, but when the parent is there and calm and supporting them, then can make the experience much better. And also the parents support each other to enable them, you know, have the child have a good experience of surgery and recovery. Afterwards, of course, we rely on them to give the pain-killing medications, make sure the child is not in pain after surgery, remove the dressing and make sure the wound doesn't get dirty and infected. So pediatric surgery, you really have to work one-on-one with the parents, make sure they understand everything, because once my part as a surgeon is done, you know, my part takes maybe only 40 minutes. The rest of the care of this child will be in the hands of the parents, and that's why as a surgeon, as a pediatric surgeon, you really have to work hand in hand with the parents. You're part of the same team.
Wow, this is a very interesting conversation that we cannot end in just one show. I agree. And for our viewers, you have been a great audience. I know because of time we can't, you know, carry on, but I see the questions coming in. Please make sure they should come so we can even continue this conversation on Facebook and YouTube. You know, this is serious. And Doc, thank you so much for such an insightful discussion. There's so much to learn today. And for our parents, if you are out there, it is important that you understand that whenever such issues arise, Doc is telling you that is the point. You have to go to the hospital, involve the health workers. Do not assume, do not be reluctant. We've had so many parents and people here becoming reluctant about these surgeries. Prevention is better than cure. Friends, this is Healthy You Talk Show on Faith Today Television. My name is Enock Kitondekijja. Until we meet next time, stay proactive, stay informed, and stay safe. God bless you.